Hi, this is Elizabeth, and this is my barium enema trigger. I have my supplies that I will be needing set up. I have my barium bag or little tube, along with my clamp and my enema tip. I have plenty of lubricant for my tip. I have gloves so I don't get messy, or in case I do, I can, be clean. I have tape. I have my air inflator, more clamps, and I have my inflator, my little bulb for air, and I have plenty of towels in case it gets messy. I have a lead glove for the radiologist and a compression pad ready to go. I have a little thingamabob, so in case it gets messy it won't get on the sheet. I have my lead ready for my patient, and I'm going to set up the console for my barium enema, and I will be using for all my images a 14 by 17. I'm going to go over here and set it up for barium enema. And I would start with my KUB, which I'm going to do 80 kV at around 32 Mass. And I'm going to go get the patient. Okay, so I've got my barium hung from my IV pole no more than 24 inches above the anus of the patient. And I'm ready to go get my patient. Christy? Hi, Christy.
Hello.
My name's Elizabeth. I'll be helping you with your exam today.
Okay.
Tell me your name and your date of birth, please.
Christy Benscoter, August 8th, 1989.
Okay. Any chance you could be pregnant? This is very important.
No.
No chances of being pregnant.
No.
Okay. Question. Did you have a nice night last night?
No.
Is it not pleasant at all?
It's not.
Okay. So that means you prepped.
I did.
Okay, so we're going to start off by taking an image, and we'll have the radiologist look at it, make sure that your colon is entirely clean for our images, okay? So we're going to have the patient get on the table. I have my 14 by 17 in here, lengthwise. I'm going to detent my tube to my table. And for my Scout KUB, I'm going to center at the iliac crest. I'm going to shield my patient. And we're going to make sure her colon's clean. Okay, go ahead and take a deep breath in and blow it out. Okay. So I'm going to go have the radiologist look at the images, and then if he says that we can go ahead and get started. Okay, so radiologist took a look at it, took a look at the Scout, said we're good to go. So I'm going to let my patient know that we're going to be ready to be tipping. So I'm going to have my tip ready. Barium bag is no more than 24 inches above the patient's anus. I have a lot of lubricant jelly. I'm going to be putting it all over, generously all over the tip. I'm going to be inserting the tip no more than 4 inches. I'm going to be going in 1.5 inches anterior towards the belly button and superior following the curve of the sacrum. So go ahead, Christy, I'm going to be inserting the tip now. Go ahead and take a deep breath in and blow it out. Let it out. It's going in. Good. Doing okay? Okay. So so just be aware that the tip is still in you, and it's going to be in there throughout the whole entire exam, okay? Okay. Radiologist is going to come in a bit. And we're going to get going. Okay, so radiologist is now present, and he's going to be going ahead and doing his spots, and I will be assisting. Once he's finished, he will let me know that we need to do our overhead projections, and I will be starting with my D-cube, so right and left lateral. My kV and mass range would be 110 kV to 40 to 60 mass for both of them. And then I'll be proceeding for my REO and LAOs, and my lateral rectum and PA, and rectosigmoid PA axial, and then I'll finish with my post-evac. So we'll go ahead and get started. So the radiologist will be inserting the barium enema until it reaches the left colic flexure and air until we see the terminal ileum. So the doctor has already left the patient in the lateral recumbent. So we're going to go ahead and start with our left lateral DQ. I'm going to be moving my cane. Center ray is going to be horizontal. So I have my center ray horizontal entering at the mid-sagittal plane and at the level of the iliac crest for my D cubes, right and left. Center ray is horizontal, entering at the mid-sagittal plane at the level of the iliac crest. She is in a left lateral decubitus, showing the lateral side of the ascending colon and the medial side of the descending colon. We're going to take a quick picture. I'm going to have my patient carefully rotate over to lay on her right side. Good. You doing okay?
It's a little uncomfortable.
No, sorry. So we're going to have her back closest to the IR, and she is now in an LAO. No, we're not in an LAO. My patient now, I had her rotate into an right lateral decubitus. We're looking at the medial portion of the ascending and lateral portion of the descending. Center ray is horizontal and again entering at the level of the iliac crest through the mid-sagittal plane. We'll go ahead and take a quick picture. Okay, since my patient was in a right lateral decubitus, I'm just going to go ahead and do a right lateral, looking at the rectosigmoid area. I'm going to go ahead, center ray is going to enter mid-coronal plane at the level of the as-is, and center ray is perpendicular. And the patient was already in a right lateral decubitus. I'm going to go ahead and shoot my right lateral, looking at the rectum. Center ray is perpendicular, entering the mid-coronal plane at the level of the as-is. I'm going to be taking a quick picture. I have my 14x17 and with all these projections for my REO and LAO that are coming up. I'm going to use 110 kV at about 40 to 50 mass again. I'm going to have my patient rotate 35 to 45 degrees, coming into an REO. REO looking at the right hepatic flexure, and take a quick picture, and then once we're done here, center ray is horizontal. 1 to 2 inches lateral to mid-sagittal plane, and then I have my patient roll towards me 35 to 45 degrees into an LAO looking at the left splenic flexure. Once again, this is the center ray is entering 1 to 2 inches lateral to MSP plane. So for my LAO, I'm going to have my patient just lie flat onto her stomach. Go ahead and lie flat. And careful with your tip. I'm going to be doing just a straight PA, looking at the colon. My center ray is horizontal and at the level of the crest. I take a picture, and then after this PA projection of the colon, I'd go ahead and do a 30 to 40 degree angle caudal to look at the rectosigmoid area. I have my 30 degree there. I line up my Bucky with my table, or my tube with my table. And this center ray enters at the level of the as-is. And then I'm going to have my patient go to the bathroom and evacuate all the barium enema as you can. And then we'll come and do the post-evac. So now I have my patient, Christy, go ahead and I'm going to be removing your tip, so brace yourself. Okay. And I'm going to have you go to the bathroom and try and evacuate everything you can. Just let it out, okay?
Okay.
Just let it go.
All right.
Okay. And then come right back to me when you're done.
Okay.
And here are some towels. You may be needing them, okay? Hold on to this while you get up. And then just close those cheeks, sister.
Two.
Oh, let me get this out of the way. Okay. Before you get up.
Oh God. Oh God.
Okay, close your legs.
Oh God.
Close your legs, honey. Okay.
You know you guys don't actually have to do.
What?
Okay, so you try to get
Best
everything
poop
out?
of my life.
I'm glad. So I'm gonna just take one more quick picture.
Okay.
So we know what we're dealing with, okay? And then we'll get to go home. Yes. Go ahead and lie onto your back. I have my 14 by 17, and again, we're using like 80 to 90 kV at 30 to 40 mass. I'm tinting my tube. Okay. For this last image, centering at the iliac crest and center ray is perpendicular. Okay. We're going to take one last quick picture. Are you ready?
Mm-hmm.
Okay, Christy, we are all done. Radiologist said that you're all clear. Good job.
Good.
Okay, go ahead and get up. So I have some instructions for you. You're going to be, barium is a very constipating substance, so make sure to take a lot of water for about 2 to 3 days just to be on the safe side. The way the barium came in is going to be coming out, so it's going to be white in your stool, okay?
Okay.
Do not be alarmed. If you have any severe abdominal pain, contact your physician. This is for you.
Thank you.
You're welcome.
All right.
We're done.
Now to evaluate the PA projection of the large intestine, we have the entire colon viewed from left splenic flexure down to the bottom rectosigmoid area. And here we have the post-evac, once the patient has evacuated all barium as they could. For the PA axial of the rectosigmoid area, we can see the entire rectosigmoid area shown and centered to the center of the IR. Here we have our PA oblique REO position looking at the right colic flexure, and there we see it without superimposition, and we have the entire flexure open and compared to the PA projection. This PA oblique of the LAO position is similar to the REO, only this shows the left splenic flexure in entirety with less superimposition as opposed to the PA colon one. So we see that nice left flexure. For the lateral view of the rectum, the entire colon does not need to be demonstrated, just the rectal part of it. Here, as you can see, we have the right lateral decubitus showing the medial side of the ascending colon and lateral side of the descending colon when we're using a double contrast like we did. And lastly, for our criteria, we have my left lateral decube showing the lateral side of the ascending colon and the medial side of the descending colon when it is inflated with air like we did. And that is it.